I started this program a few weeks ago, I interchanged the terms DNP and FNP. So what I've learned so far is that the DNP isn't a role or a licensure, it's a degree. It isn't meant to certify the advanced practice nurses in their specialty of healthcare or define their role. The DNP can be used successfully in various ways, like example, executive leadership path or patient care path, or even down the scholarly academic path. Regardless of what it is, that's chosen, all practicing advanced practice nurses with the DNP are expected to understand and practice the 8 DNP essentials. Those place an emphasis not solely on the individual patient, but target populations, demographics, etc. I still don't fully grasp the entire role of the DNP, nor how I fit into that framework. It's not a concept I'm familiar with. I'm used to focusing on the patient in front of me and their disease process. I never spent a lot of time looking on patient or target populations or big groups or policies or evaluating QIs, and definitely not sifting through research and creating evidence-based practice guidelines at all. One area that falls under the DNP that I'm not sure how it fits in with us is the CRNAs. I can see how the 8 DNP essentials work for nurse practitioner, midwives, and specialists, but the CRNA seems like their focus is strictly pre-op or inter-op around the L&D unit, and I'm not sure how that addresses the community or policies or evidence-based practices. I did learn a big difference between the PhD and the DNPs that the AACN really wanted to establish. There was a difference, for example, a research base versus a practice base, referring to the DNP project as a project and not a dissertation, so the two weren't confused. So this is kind of how I look at it. The folks with the PhDs do tons and tons of research, and me with the DNP take that information, sift through it for validity and limitations, and help develop evidence-based practice and guidelines. And then the PhD folks go back and look at those guidelines and get more data and research, and then we just continue to do the circle and go hand in hand with each other and come up with the best patient care guidelines. Family nurse practitioner can stand alone with either a master's or a doctorate degree. What the DNP does is bring that extra level of research, evidence-based practice, and executive leadership and healthcare system organization and management to their patients. The Affordable Care Act, passed back in 2010, was established to try and kind of connect the patients with their providers, to decrease costs and place an emphasis on prevention and healthy lifestyles, and try to bond the public and private sectors of healthcare. The problem was there wasn't a great plan to increase the number of those providers for all those patients, nor were there systems designed to handle the influx of newly insured patients. There weren't systems in place to emphasize healthcare prevention or address the patient population needs. The concept was to ensure that everybody had access to affordable healthcare and reward providers based on outcomes and not just treatments. It is a great idea. It essentially revamped the traditional healthcare system and its framework. Family nurse practitioners are one component to that void. Nurses are the largest sector in the U.S. healthcare workers area and come with vast backgrounds of experience. They've been on the front line through their careers, and they relate to their patients better than most healthcare professionals, so transitioning to an advanced direct patient care would be easier for them than it would be for others. The DNP role offers something a little different than everybody else in that it advocates policies and systematic changes for the target population. It uses evidence-based practice to treat patients, and that FNP certification is the hands-on provider for those practices. They can evaluate data, they can implement guidelines, evaluate outcomes, and either make changes, and they can disseminate information based off what they've learned. I think the DNP essential that resonates the most with me is the 6th one, interprofessional collaboration for improved patient and population outcomes. I know I don't know it all, and only a fool would try to approach a systematic issue or a complex patient by themselves without input from any other specialty. In my practice, I rely on many other experts to develop guidelines and care plans that I carry out on their behalf without their presence. I have to have trust in their knowledge and experience that the treatment plan before me is the best as evidence-based practice for that patient. It's my responsibility to perform those treatments, to observe for changes, and to ensure that I'm in the right guideline for the situation. I rely on pharmacists heavily to develop the appropriate medication regimen for the patient without causing any undue harm. And I rely on telehealth medicine quite a bit when I get into a situation that's not going according to plan. I have to be their eyes and ears and communicate effectively and clearly in a chaos environment, and I have to trust their guidance. I have to rely on my dispatchers at our air medical company that they are going to lead me into a safe and controlled environment, and they're also a resource for me if I need to communicate to any other entity outside of that situation. Everything is a team, from the radiology group who does a great job taking x-rays and is proficient in what they do, to the lab people who are very precise and efficient in their arena. It's all about the patient, and there's no way that it could be done just by one individual. I think the FNP competency that resonates the most with me is the one about practice inquiry. The AACN describes it as implementing new knowledge into practice, analyzing the evidence from practice, investigating the skills, leading the practice inquiry, and then using that information to develop care models and plans and to disseminate out that information. In my early practice, I did not like this at all. I didn't like to analyze things. I didn't like to see if they worked or if they didn't work, and I definitely didn't want to lead anything or publish anything at all. But now, years later, I actually enjoy evaluating things, how they work, the policies, the guidelines, and if they're effective. I used to think there was an end game to healthcare, that if we continually did this thing, that we would reach this mecca of an end game. The truth is, there is no end game in healthcare, ever. It's always evolving. It's always changing. The best practice of today may not be the best practice of tomorrow. And that doesn't reflect an error in treatment. It just represents evolving research and technology that may have found something better and something that's more cost effective. Explain something unique about me. I think something interesting would be I should have been dead twice, and I'm not, actually 3 times. When I was little, I drowned in Pineview Reservoir, was taken out and had CPR performed on me and mouth-to-mouth on the beach, and was resuscitated quickly after that. In my career as a firefighter, I fell through a 3rd-story floor in the middle of a burning building on an apartment complex, and luckily got hung up on the joist of the floor of the 3rd floor going down into the 2nd, the level that was completely engulfed in fire, and had somebody pull me out. And then just recently, in the last couple of years, I was in a car accident that there's no explanation at all as to why I didn't get injured more from the head-on collision than what I did, because everything else in front of me and around me and behind me was totaled, but somehow there was just a little pocket that I was in.